Please begin.
Okay.
Okay. Uh, I'll start with the introduction, madam.
As you feel like.
Okay, so good afternoon, everyone. I'm today's webinar coordinator, Dr. Rutu Pari. For today's webinar, we have a speaker, Dr. Mansi Soni, with us. She has done her bachelor's and master's in neurology from Government Physiotherapy College, Ahmedabad. She is currently pursuing her PhD at ARIP Charosat. Her areas of interest are stroke rehabilitation, physical activity measurement and enhancement, and electrodiagnosis. She has more than 13 years of experience in teaching. Currently, she is working as an assistant professor in ARIP Charosat. She also has done many publication in various journals with good impact factor and Scopus Index journals and won many prizes in scientific presentations. So now I would like to request Dr. Mansi Soni to start today's topic of webinar. I welcome you, ma'am.
Thank you. Thank you very much, Dr. Ritu. Uh, this was quite a warm welcome for me and would definitely like to go ahead with my presentation now. So for that purpose, we'll be sharing my screen with you all people. Okay, hope my slides are visible now.
They are visible.
Okay, so we'll go ahead with today's topic, that is importance of physical activity for patients with stroke. This is basically one of my area of interest, as Dr. Rutu has already informed you. So I'm having the personal touch in this particular area of interest as well. Okay, now moving towards the component that will be included in today's presentation is we will be covering stroke burden. We will be talking a bit about definition of physical activity. We will be going for the importance of physical activity. Here we are going to have more of content that is stroke specific. But before going for the stroke specific component, we would definitely go for the outline component, that in general population to what extent it is important. And then going ahead at the last component, we will be talking about the actual scenario that's there at the physical activity level among the stroke patient. So what's the actual scenario and where we are lacking or what else can be done, that will be concluded at the end. So first, moving towards the stroke burden. Okay, here I'm sharing the slide that is everybody is familiar with the World Health Organization. We are knowing that the data set that is generated at this large scale component, that is everybody is using it. And if we are seeing here it is showing you the global cause of disability as well as death component. First column, if you are seeing, it is the top 10 global causes of the death that is reported in 2019. Now, if you are seeing for the causative component of the death, first one goes at ischemic heart disease, second one goes at the stroke. So when we are talking about the stroke, we are talking mostly in terms of the neurological deficit that is coming. But it's not that only, it is the second largest cause of death also as reported in 2019. Now, if we are talking about the other components are there, that is COPD, respiratory condition and all sort of thing. But if you are talking about the stroke, it is quite large as expected. Compared to disability, even the death component it ranks higher. Now, if we are talking about the disability that is coming with the stroke, disability is basically, here you can see the terminology DALY. Disability adjusted life years means whatever life you are living, to what extent that added years are there but with the disability. So if you are seeing this one also, neonatal condition, it is very obvious. See, when you are saying at first level neonatal condition is that if the child has got disability impact in the childhood itself, comparing the lifespan, it is very obvious if the condition is neonatal one, it is going to be having the largest component of disability adjusted life years, because the child is supposed to live longer as compared to the person who is getting affected in the adulthood, late adulthood or even geriatric phase. So if we are seeing here, it is very obvious to have neonatal condition as a first cause. But if you are seeing here also, stroke is the third leading cause for having the disability adjusted life years. So it is not only the higher level cause of death, but it is causing a higher level of disability also when we are talking about the global impact. Okay, now coming to some sort of variation. When we are saying globally, global burden of disease report again has further classification component that we are knowing that scenario is not always similar when we are talking about the higher income countries or lower and middle income countries. But if we are talking about the stroke impact in form of disease burden, this global burden of disease has reported among the higher income country, it is the third leading cause of disease burden. Disease burden comes in all sort of form. It is disability adjusted year. It may be the costing that the people has to bear for and all sort of things. So higher income countries, it is third leading cause. But if you are seeing even lower and middle income countries, stroke is considered the seventh leading cause of disease burden. These two slides are quite sufficient enough that if we are talking about the top 5 or top 10 conditions which is causing the disease burden, stroke is falling at each level. So here it is something that we already need to pay larger level of attention considering that consequences stroke is going to bring. Okay, now everybody, I assume that physiotherapy students, probably the final year students I'm expecting here, everybody might have seen the patient with stroke and you might be knowing that it is not only one-sided weakness, it is bringing so many consequences or complications, or it comes as a lot and lot of functional ability issues. So what kind of impact stroke is causing? It is not only one-sided of weakness, but it is beyond motor weakness. It brings some sort of sensory issues. It may be causing cognitive issue. It may be leading to speech deficit and all. So thus it is causing the wide range of impact. Now if we are seeing all this wide range of impact, it is very obvious that rehabilitation needs to be extensive one. It need to be having each and every component to being given the major importance and all. And along with that, this non-communicable disease is not something that gets over within 3 months and 6 months and so on. Seeing that effect last for the years as well. Okay, excuse me for the thing. Okay, now if we are seeing that it is causing the impact which is lasting for the longer duration, okay, still we can manage with the rehabilitation, but it brings another consequence as well. That is something which is in the form of recurrent stroke. So person gets a stroke, recovers to certain extent or completely also, maybe, may not be, but it is likely that almost 30% of the stroke cases are likely to have the second episode of stroke. So 3 out of 10 people are likely to have the recurrence of the stroke also, and that's why to avoid the long rehabilitation, larger consequences and possibility of recurrence, it is better that if we don't only give the importance to the management of stroke, but there has to be the need for having some sort of thing which can prevent the stroke itself. So prevention needs to be given major emphasis here considering the global disease burden it brings. Okay, now when I'm saying or we are saying that it is a prevention needs to be given importance, it is a preventable one, we need to pay attention what causes stroke. So what are the risk factors for the stroke? That can be divided into two major categories, modifiable risk factor and non-modifiable risk factor. Okay, if we are talking about the non-modifiable risk factor, you cannot do anything in that particular thing. If it is there, it is going to be there only. But larger scope is there at the modifiable risk factor. Now, if you are saying it is modifiable means you can change it. So all these modifiable risk factors are mostly related with the lifestyle component. It may be some sort of disease prevention strategies. It may be something which you can change your lifestyle practices and then will be bringing the risk reduction. Okay, now if we are talking further about the modifiable risk factor, which one is the most common modifiable risk factor we are going to target here is physical inactivity. Now, if we are seeing the activity level of the people, it is already very less. That's what we will be seeing as a key fact component also. But if we are seeing that people being inactive, people being sedentary, people being more into the leisure activity or no work or no physical activity component, it is considered that it is causing the higher level of risk. And this one is identified among the top 5 risk factor that is there for the stroke. So if we are saying it is among the top 5 risk factor, being modifiable, if something can be done for this, it will be bringing the lot of advantage at the patient's level or at the general population level as well. So considering this, physical inactivity needs to be targeted. And how can be targeted? We need to take steps to make the patient more and more active. Now, when saying more and more active, who all need to be active, to what extent need to be active, and what's exact scenario it is existing at the general population level, that we are going to see now. Okay, before going to the general population related physical activity, we need to be knowing very basic thing about what do you mean by physical activity. Okay, now if we are talking about the structured definition form, here I am quoting the definition that is defined by WHO. Physical activity is considered as bodily movement that is produced by the skeletal muscle, but that is having one more component, that this movement needs to be requiring some sort of energy expenditure. So here you can say that physical activity is defined as skeletal muscle movement requiring the energy expenditure. Now, when we are talking about energy expenditure, we know that it goes in the form of kilocalorie, it can be going in terms of metabolic equivalent and all. So those components will be part of physical activity. Okay, now coming back to the physical activity, which all component will be there as a physical activity. Now here it can be any of the skeletal muscle movement which the person is doing as a leisure time activity. It may be for the transportation component, walking to and fro, using the transportation vehicle and for that mobility component and all, or as a part of the person's work life. Work life doesn't mean that if you are going to the occupation that only will be considered as a physical activity. When we are saying as a part of person's work life, this work life incorporates both the thing. If you are considering it as an occupation work life, yes, it is a part of it. If you are talking about the housewife or homemakers, yes, that home related activity also is a part of physical activity. So when we are talking about the physical activity, all these movements will be considered as a physical activity. Okay, now coming to the definition again, I said whatever definition that skeletal muscle movement and requiring the energy expenditure. This one was first defined by the Kasperson in 1985. As you can see, the similar definition has been used in 2018 by WHO also. So this particular thing says that this particular definition is widely in the use at various level. Even if you are seeing 2019 British Medical Journal, this particular journal, BMC also has said that this one is the valid definition and it is still in the use. So this is about the physical activity. Okay, now from the definition part, let's move towards the key fact component. Now, when we are saying key fact component, again, this key facts that are coming from the WHO that's being discussed right now. Okay, now when we are talking about the physical activity, it has got two particular headings or titles under which the benefits or key facts will be discussed. One is health benefit and the second one is there, that is condition specific benefit. Okay, now when we are talking about the health benefit, the physical activity has been found that on heart, body and mind, all three, it has got the positive influence or it has got some sort of beneficial effect. Now, if you go to your definition of health, you can consider that it is not something which is only at physical level, but it has to incorporate beyond your physical level also. So health definition, if you are considering, all the component that is needed for the good health part, it is getting benefited by the physical activity. Now coming to the second component, if you are doing some sort of activity, you have to have so many components related to thinking, learning and judgment. Now physical activity is found to be beneficial for all three domains as well. It has been found that it enhances the thinking, learning and judgment component. And now ultimately, if we talk about the growth and development, it is helpful or beneficial for the normal growth and development as well. So these all are the health benefit. Now let's go condition specific. Everybody know that when we are talking about the disease burden, this non-communicable disease also is getting larger attention nowadays. And this non-communicable disease, it has been identified that physical activity brings beneficial component to all the condition mentioned here, whether it is cardiovascular condition, it is carcinoma, it is diabetes. NCD, why it is important? It is something which is resulting into the chronic disorder. All these things, if we are seeing, it is not something which comes and goes like that. So in such kind of situation, physical activity is much more important. Mental health issues are also gaining popularity nowadays or increasing with the prevalence rate. Considering all those things, if we see, physical activity has been found to have some sort of beneficial effect in the area of mental health also. Specifically, two conditions here I am mentioning, that is depression and anxiety. Both these conditions are being benefited by the physical activity. Now, if I am talking in terms of the overall health related thing, if it is enhancing the functioning of heart, body and mind, it is enhancing thinking and learning component. It is very obvious, it is helping so many non-communicable disease. It is helping some sort of mental health component, and thus it brings overall health benefit to the larger scale. Thus, if we are seeing overall package of the physical activity benefit, it goes beyond your expectation. There are larger number of areas which get benefited by the physical activity. Now, if we are seeing that, okay, everybody knows that it is giving some sort of benefits. Now we are knowing that it brings beyond the imagination some sort of extra benefits also, being condition specific or being organ or process specific. Let's see that whether if it is important, people are utilizing its benefit to the optimal level or not. That one also needs to be seen. That is again a part of key facts that is coming from the WHO. Okay, now when we are saying it is important, it is important. Yes, if it is important, there has to be some sort of recommendation level also. So if we are seeing whether we are falling at the category of recommended level or not, it is very poor finding that only 1 in 4 adult globally doesn't meet the recommended level. So it is something where you need to pay extra attention, that even if knowing the benefit, almost 25% of the adult fail to meet the recommended level. And this one, we are not talking about the lower income country or middle income country, it is the global one. So if we are seeing, it is quite high. Now coming to the adolescent population, see, recommended level, if you people are interested, you can refer to the WHO's web page for the physical activity. You will be getting the different recommended guideline. Adolescent recommendation is somewhat higher as compared to the adult. And if we are seeing, adolescent population is expected to have much more higher physical activity as well. So considering that higher activity requirement or higher activity expectation, still if we are seeing more than 80% of world's adolescent population is not sufficiently physically active. So they are also found to be physically inactive. So somewhere for the adult, 25% of the people fail for reaching to the recommended level, and adolescent population, that's why probably the childhood obesity and getting it as a adulthood obesity raising issue is going to get increased more and more with this particular component. So meeting recommendation, here we are seeing that despite of knowing enormous benefits and all, the level of recommendation is still not met at many levels. Now, if we are seeing that, okay, it is important, it is important, it is important. About all those things, yes, it has got beneficial effect of heart, body, mind. It has got beneficial effect for NCD, mental health. But if we are seeing what consequences it brings, if insufficiently active, it is likely to be causing even death component. And that is something where we need to open our eyes widely, because 20 to 30% of increased risk of death is found in insufficiently active people as compared to if the person is living sufficiently active lifestyle. So if the person goes for the normal recommended level of physical activity, some sort of risk protection against the death is assured. With this particular statement, at least we can say, even if we are working on this particular domain, we are working for increasing the physical activity level, we are likely to reduce 5 million deaths globally. So this is possibility that by simply working on the physical activity level, you can bring the larger level of benefit as well. Okay, now let's go towards the stroke and physical activity. As the demand of today's topic, we are going to discuss a lot about this particular component only. Okay, now when we are talking about stroke and physical activity, here I am quoting two evidences downside in the dark green color. If you are able to see, there is wide range of high quality research evidence which says that stroke risk reduction is there with the high level of physical activity. So high level of physical activity means you can say that vigorous physical activity, if the person is incorporated into it, it is definite that it will be bringing the stroke risk reduction significantly. Even if person is not involved into high level of physical activity, even the person if involved into moderate to high level of physical activity, still it has been reported with many of the evidences that it says that it will be decreasing the incidence as well as mortality associated with it. So here it says that yes, stroke is likely to be benefited by the physical activity, and this has been supported by the evidences as well. Okay, now when we are saying that some sort of risk reduction is there, here I am quoting some sort of meta-analysis finding as mentioned downside in the reference, that specifically when we are talking about the ischemic stroke risk reduction, the physical activity level is likely to bring the risk reduction, and this risk reduction is going to be in line with, particularly if the person is involved into the low physical activity as compared to the sedentary individual or inactive individual. 16% risk reduction has been analyzed and found. If the person is involved into the moderate level of physical activity, it will be tapering down the risk by 19% as compared to inactive individual. And if the person is involved into the high level of physical activity, the risk reduction is almost 26%. So if you are seeing here whether the person is involved into low, moderate or high level of physical activity, it is likely to bring stroke risk down around 20%. So plus and minus 4 to 5-6%, you can see the variation, but it is observed with the calculation. Meta-analysis is something that gives the result based on the multiple study findings and calculation. This risk reduction has been calculated, so it's a valid one. Okay, now when we are talking, one more meta-analysis is there. When I'm saying that risk reduction is there, would further like to see that whether the male and female are getting benefited equally or not. So here the gender specific comparison meta-analysis, the other one is here. So this one was 2010 meta-analysis, and that one has reported that male, if involved into the moderate level of physical activity, it will be tapering 12% of the risk, and if involved into the higher physical activity, will be benefited by 19% of risk reduction. Now, contradicting to the male, here you can see If female is incorporated into the higher level physical activity, the risk reduction is going to be 24%. If you are able to see here, there is no risk reduction coming with the moderate level of physical activity. What does this mean? This says that female will be requiring higher level of physical activity for protection. If they are incorporated into the low level of physical activity or moderate level of physical activity, they will be comparatively benefited less as compared to male. But again, if you are seeing the higher level of physical activity, here it is showing that male are getting benefited with 19% risk reduction, while female are having the still higher risk reduction, that is going for the 24%. So here the win-win situation you can consider for the gender-based component. Female will be definitely requiring the higher level of physical activity for risk reduction, but at the same time risk reduction is also higher. Male, even incorporated into the moderate level of physical activity, are having the beneficial effect. Now if we are seeing all this component here, majority of studies are commenting on the ischemic stroke. So hemorrhagic stroke, everywhere it is not the majority of population. All this data, majority of the things can be applied for the ischemic stroke. Okay, now when we are talking about the risk reduction it is bringing for the stroke patient, we have to be knowing that what is the recommended level of physical activity for the stroke patient. Now when we are managing the stroke, we have to consider the prevention aspect as well. So when we will be discussing about the physical activity recommendation part, we need to be seeing it with two components, that what when you are targeting stroke as a prevention component only, you are targeting physical activity to reduce the stroke risk on the onset or first ever stroke itself, or even recurrent stroke. Yes, it may be there. And then the second one is there, when the patients are having already stroke, what level of physical activity they need to be involved into. Okay, now coming to the stroke physical activity recommendation. This particular thing is coming from the American Heart Association. Now, if we are talking about that what is recommended for the patient with stroke, they already have the episode of stroke. So you need to respect that particular thing. You cannot have the similar level of guideline what you are giving it for the normal healthy individual. So if the patient has got stroke, he needs to be prescribed some sort of activities which will make him work for more than 3 days per week for 20 to 60 minutes daily at 40 to 70% of VO2 max or heart rate reserve. Okay, everybody, when prescribing the aerobic exercises, we are utilizing the formulas and all for utilizing it at what level of VO2 max or heart rate reserve. A heart rate max calculation is there, and then you are calculating age specific component where you can go up to what maximum level. All those things being utilized here, and you will be making sure that patient has to work for more than 3 days per week, and it has to be there in 20 to 60 minutes daily. Now, when I'm giving it range, you may be having some sort of variation, that 20 minutes or 60 minutes or in between 40 minutes. You have to consider the overall cumulative component. So if I'm saying upper limit 60 and 3 days component, if I'm considering, it goes around 150 to 180 component. Okay, so that many minutes has to be there. So 150 to 180 minutes has to be there weekly, and each session has to be at least minimum 10 minutes. You cannot have 5-minute session at all. 5-minute session, if the session is lasting for less than 10 minutes, it is actually not going to be helping you anything at the aerobic component level and will not be serving for the beneficial effect that we are seeing. So all this guideline or recommendation that is there, they are saying that at least a 10-minute continuous session has to be there. It may be multiple session. If I'm saying 180 minutes per week, It can be 10 minutes, 18 session, that's fine. But it need not be something which is less than 10 minutes. If patient is able to do 20 minutes, 60 minutes at a stretch, very well. If not, at least to 10 minutes. Okay, now what needs to be done? Now, when you are saying the stroke patient, you already know that the stroke has stages of recovery defined by Bronstorm. You know that already functional ambulation category is there. Patient will be dependent in the initial phase and then gradually will be coming to the independent level. So if we are seeing the initial acute phase, patient will be having many deconditioning effect and complications associated with that are likely to be occurring at peak. Now here in this particular situation, you will be choosing rather than continuous mode, you will be going for the intermittent mode. Intermittent mode means you will be choosing the session for 10 minutes only in the earlier phase, and then you can progress towards the higher level of duration. Now, if you are saying that activity needs to be done, what kind of activity you will be targeting? Here you can be targeting any of the activity or many of the activity, whatever you want to do. But when comes for the outcome out of it, strength training is identified as something which is likely to cause the improvement in the ADL part. So if you are targeting the independence in the ADL, you will be benefited more if you are prescribing more of the strength training. Strength training, everybody knows. I don't need to tell in detail that you are incorporating resisted training, you are incorporating some sort of inclination to the walking, you are increasing resistance to the bicycle. All these are the ways of strength training. Flexibility training, when you are doing some sort of flexibility related component, it is bringing betterment in the balance as well as coordination. So this is about, we are talking about the stroke patient. Patient needs to be doing activity at least 20 to 60 minutes, more than 3 days a week at 40 to 70% of heart rate reserve as mentioned in the previous slide. Okay, now this is what is for the stroke patient. Okay, now if we are seeing that we are working for the prevention, so is there any specific guideline for prevention as well? So coming to that part, separate guideline is not there for the prevention of stroke. So if you are targeting prevention, there is a general guideline where you are doing it for the individuals to prevent the long-lasting complications or some sort of deteriorating effect and all. So that particular recommendation is in line with the current US general preventive guideline. So again, the first one was given by American Heart Association. This one also comes from the American Heart Association only. Now here, the previous one was telling that it has to be there in the range of 40 to 70% of VO2 max or heart rate reserve. Here you will be going a bit ahead with that particular thing because you are working for the prevention part. So what needs to be done? It has to go into moderate to vigorous intensity exercise, and this has to be going 40 minutes per day for 3 to 4 days a week. So this one again will be going in the range of 150 plus minutes per week. It is almost going into the range of 160 to 180 minutes. And if you are seeing that here the terminology used is moderate to vigorous intensity. So moderate and vigorous intensity, if I want to simplify to you people, when you're working or you are running at your pace, which is making you breathe somewhat harder, it will be considered as a moderate exercise. But if you are running faster, which makes you breathe tremendously hard, it becomes the vigorous exercise. So here you cannot have some sort of comfortable activity. You have to challenge your potential and go in the higher range, and that also more than 40 minutes per day for 3 to 4 days a week. So this is about the preventive guideline that is there for the general prevention. And this one is only applicable if you are working for the stroke prevention. Okay, now coming to recommendation is there, but if the person is using that particular recommended component, or even if failing to do the recommended level, is it bringing some sort of beneficial thing? Yes, it is something which has found that will be benefiting in many ways. Now, why it is important to see functional recovery for the after stroke? When we are seeing functional recovery, you might have observed many of the patient, and even after 12 month, 18 month, 2 year, 5 year, 10 year down also, you are seeing patient who had got stroke in past but still has got some sort of disability or deficit. Now, that particular component is, here the finding says that 1 of 3 recovers completely, means 2 are still there who will be having long lasting deficit. And this 2 are something which comes to us after 2 years, 5 years, 10 years, and so on. What all things can be that? It may be minor involvement also. They will be walking with some sort of assistive device, some sort of orthosis component. They might be having some sort of deviation also. Independent component can be there, but still so many things will be there. Okay, now if we are talking about, when I'm talking about the assistive device and orthosis, furthermore, one eye opener is that is around 20% fails to achieve independent walking. So they are dependent on the orthosis or assistive device in such kind of situation. And this particular thing is something where you need to do something which will be making patient to fall into the category of one who recovers completely or who will be having the minimum amount of deficit post stroke. Okay, now what is the finding? Whether this physical activity, what we are talking, is giving you some sort of benefit? Yes, the benefit comes, and again, when I said about the recommended level from the American Heart Association, that what strength training serves and what flexibility training serves, that is to be recommended or referred here as well. That overall it has been reported in one of the review, that is by Galanag, as this review has said that so many forms of exercise or physical activities are being prescribed in the patient with stroke, and it has been identified that irrespective of what type and what kind, overall beneficial effect is assured in the functional recovery. Now, when you are saying that, okay, if you are prescribing physical activity, it is making the patient recover functionally in a better way. Now, if the patient is recovering in a better way, it should be very obvious that the patient need to be reporting some sort of independence in the overall daily activity as well. But this review again has reported the contradictory finding that yes, all these things can be increasing the functional recovery, but it is not necessary. It will be reflected in the day-to-day activity. Here I would like to quote the example for the gait speed. We are considering that if the person is walking more than this particular gait speed, it is considered that person is capable to walk in the community. Person has low risk of fall, no risk of fall whatsoever. But with that high speed of walking also, it's not assured that patient will be walking in the community for sure. Patient may not be doing it also. When you're asking your patient to button or unbutton the shirt, they probably will be. But as a part of their routine life, are they using that buttoning and unbuttoning activity? No. Probably many of the patient will be changing their dressing pattern, which doesn't require the finer movement. So it is not necessary that functional recovery which has been obtained will be utilized for the participation component also. So this is something which is to be targeted again, that you don't make only recover functionally, you tell them, you motivate them to actually do it or incorporate into the routine life as well. Okay, now physical functioning we have talked. The second part is there, that is cognitive functioning. Now when we are talking that motor sensory deficit is there, what else comes into the mind after the stroke? That is cognitive dysfunction. Now if you are seeing cognitive dysfunction, being the physios or being the stroke rehab team member also, this cognitive function will never be primary objective to deal with. Your patient also will not be telling you that my cognitive deficit is this and this, you do something for this. They'll be saying, I want to walk, I want to eat independently, I want to dress independently, groom independently. Nowhere it is coming as a primary objective, either on the patient side or rehab team member side. So here it is the systematic review which was done in 2012 has said that as a primary objective, it was very few studies which evaluated it. It was either secondary objective, and even with the secondary objective, if you are treating that kind of thing, the intervention being given was having wide variety, and few studies only were there, which was again of low quality. So it has said that yes, positive influences are found by the physical activity on cognitive function, but still large scale RCTs and more structured studies are needed. Okay, we have one more meta-analysis, as the previous one has said that RCT is needed. So this one was meta-analysis which found again few of the RCTs were there, and they have reported that meta-analysis showed that cognitive function also are benefited with the physical activity. And this is not only limited in the acute phase, even if targeted in the later phase also, it has got the positive effect. Okay, now here some sort of cognitive areas which got benefited were also identified with meta-analysis. That is attention and processing speed measures with the intervention. So attention and processing both were improved, while when we are talking about working memory or executive function, this meta-analysis has reported that physical activity has not proven to be improving this two component. So if you are talking about attention and processing speed, yes, physical activity has been found to be effective. If you are talking executive function and working memory, it has not the definite effect reported with the meta-analysis. It doesn't mean it doesn't affect, but this meta-analysis have said that it fails to prove the superiority in this area. Okay, now everybody might be familiar with the terminology quality of life. I assume that quality of life is known to everybody, because when we are dealing with any of the chronic condition, we are knowing that the recovery is very slow. It takes longer time. You cannot, when we are dealing with the condition like carcinoma or diabetes, you know that if it remains stable, that is itself sufficient. You are not expecting the recovery to happen. So in this particular scenario, what is to be observed as an outcome of the health, that is quality of life. Rather than seeing how much pain improvement, how much swelling improvement, if actually it is making some difference in person's life or not, that is evaluated with quality of life. And physical activity has been found that even in the chronic condition like stroke, it uplifts the quality of life. So stroke patients are benefited in terms of better quality of life also with the physical activity. Now when we are saying it, it has to have some sort of component to improvise the socialization component also. So rather than having it as an individual activity, if we can incorporate patient in some sort of group activity, it will be bringing the better result as compared to the individual exercise. Okay, now coming to the particular component, that if we are saying that, okay, it is important, it is better, it is there, which has got beneficial effect in multiple areas, actually what is happening at patient's level, to what extent they are active, that is reported here with the physical activity level of stroke survivor. So when we are observing what is the actual level of physical activity, they no need to be doing some sort of 20 to 60 minute physical activity at 40 to 70% of heart rate max. Are they doing it? Now when we are seeing it, are they doing it? It is found that whether it is acute phase, subacute phase, or even chronic phase, patient fails to meet this recommended level of physical activity. It's not only the lower middle income countries only report that, even high country findings also are suggestive of the same thing. So it is found in terms of quantity, duration, intensity, all these things, the level of activity has been found lower only. Okay, it is not something that every time, it is something when the patient is not doing and it is not coming. It may be most of the time patient is not having the ability to walk, ability to perform the activity. That is something which is majority of the time patient reports this particular thing as a barrier to do the activity. Now, the second component is that is sensory motor function. Patient wants to do it, but movement is not there, sensation is not there, some sort of complication arising with this. That can also be one of the reason. Many times the slow mood and social support or family support also is a key factor which is causing the physical activity level of the stroke survivor not meeting the recommended level. Social support, family members many times will be overprotecting towards the patient, that if they will be falling, they will be bringing some other complications, and then again that will be requiring some sort of extra care and all. So all these things can also be reason. But in nutshell, if we want to do something, here are the scope where we can do something better for the stroke patient. So with this particular thing, I'm coming to the ultimate concluding component, that we are coming to the concluding slide, that we are familiar with n number of benefit that physical activity brings for the patient with stroke, after occurrence of the stroke, or as a preventive measure for the stroke also. At both the level, physical activity has been found to be beneficial. But another finding that we have come as a barrier to this, why we are not achieving the optimal benefit with this physical activity component, because when we are seeing recommended level and the level of physical activity among patient, there is wide gap. This activity reported is very less in the patient with this is modifiable risk factor. We are talking physical activity is a modifiable risk factor, but age, gender, all these non-modifiable factors are also there. Some sort of hereditary influences, having the diabetes in the family and all sort of thing, where you are already identifying that person is having the risk of the stroke which is higher. So in those population itself where the risk is higher, as a preventive measure this needs to be applied, and it will be benefiting the population. As a management part, rather than asking patient to be staying sedentary after stroke, or motivating family members to make them more and more mobile and active, we can actually patient to achieve greater risk reduction for the recurrent stroke, as well as we can help them at functional recovery level, cognitive recovery level, risk reduction level and all. So with this, we need to work somewhere in the general population as well as in the stroke affected population to bring more benefits with the simple physical activity component. With this, I'm ending my PowerPoint. If you people are having any query, let's have the discussion.
Okay, ma'am, I guess there are no queries from the student side. So
Okay.
I would like to thank you so much on behalf of Parul University for sharing your wonderful knowledge and insightful words. Thank you again.
Thank you very much.
Okay.
Shall be leaving the meeting? Will be fine.